Good morning everyone. Today we'll discuss regarding bone loss and patterns of bone destruction. Now this topic is very important in assessing the bone loss which has occurred because of the periodontal disease. Now once the periodontal disease has sets in, there will be bone destruction due to gingival inflammation which will extend along the alveolar bone leading to periodontal disease or varieties of patterns of bone which will cause bone loss, and these bone loss and patterns are important for us for the treatment planning and also for assessing the pathway of inflammation. Now the most common cause for it is because of the gingivitis extending it into the periodontal pocket causing destruction of the alveolar bone. And as you all know, most of the periodontitis is always preceded by the gingivitis, and similarly not all gingivitis will progress to periodontitis. So hence once there is a bone destruction, it is important for us to assess the patterns of bone loss or extent of bone loss and how does it the bone loss occurs, so that we can formulate a treatment, and based upon that we can give proper treatment to the prevention of the periodontal disease. Now this topic will cover entirely on the patterns of bone loss, how this inflammation from the gingiva will extend into the alveolar bone and into the periosteum, causing destruction of the alveolar crust and periodontal ligament fibers. Also, we will discuss in short regarding the radius of action and various treatment modalities available for this type of bone loss, and the rate of the bone loss will be discussed in this topic. Now, once the bone destruction has occurred because of gingival inflammation, there will be certain changes occurring in the gingiva leading to what we call it as destruction of the alveolar bone, and because of this there is variety of changes before the commencement of the loss of alveolar bone. Namely, there will be change in the organisms from the gram positive organisms to gram negative organisms, and also there will be increase in spirochete organisms which will lead to the end stage of gingivitis, wherein the fibroblast and lymphocyte from the gingivitis stage 1 will shift to what we call it as end stage of gingivitis, where the fibroblast and lymphocyte will increase and the number of plasma cells and blast cells, or you call it as B lymphocyte, will increase. Now similarly, there will be an increase in the T lymphocyte predominance, wherein the gingival inflammation will lead to all these changes before commencement of the alveolar bone destruction or the destruction of the periodontal ligament. Now these changes will see in case of advanced gingivitis, wherein all these features will change leading to progression of the periodontal disease. Once the patient brushes properly or he maintains properly, the gingivitis state will subside, leading to containment of the inflammation to within gingiva or the spread of inflammation to the underlying periodontal pocket. Now this bone destruction is due to gingival inflammation will occur, or we can extend to the supporting tissues, causing increasing the potential plaque microorganisms which will cause a destruction of the host, leading to small amount of gingival fibrosis and also changes in the width of attached gingiva, and also fibrogenesis and osteogenesis will get affected. Now once the gingival inflammation has commenced, there will be, as I have discussed in the previous slide, there will be changes in the microorganisms leading to post-inflammatory response, and this post-inflammatory response will cause changes in the pathological microorganisms as well as the progression of the periodontal disease. Now this gingivitis is contained by the conscience of the patient or the proper brushing method. There will be reversible from the gingival inflammation from stage 4 to stage 3, as well as reduction of the gingival inflammation leading to fibrosis of the gingiva, or else the width of the attached gingiva is sufficient enough to contain the infection. The inflammation will not spread to what we call it as periodontitis. Similarly, it based upon the fibroblastic activity as well as the osteogenic activity of the individual or the host response of the individual. If the host response is very much high, for example in case of diabetes mellitus, where the host response is very much affected, this inflammation will spread to what we call it as periodontal disease or periodontitis, leading to bone destruction. Now once you go for once you see histologically, the bone destruction from the gingival inflammation will continue from the gingival junction epithelium to the underlying connective tissue of the gingiva, where where there's a breach in the barrier membrane or the barrier of the junctional epithelium, leading to inflammation extension into the collagen fibers of the collagen fibers which are present in the gingival connective tissue, which are loosely arranged along the alveolar bone. Once there is a marked elevation of the host response, or because of the presence of the microbial flora which are destructive, lead to inflammatory infiltration or the reversal of the inflammation from the periodontal pocket or the junctional epithelium or the connective tissue of the gingiva, leading to increased in the T lymphocyte activity and B lymphocyte activity, wherein the inflammatory infiltrate gets concentrated, leading to a war between the neutrophils and the microorganisms, leading to either self-destruction or the destruction of the microorganisms. Now, when the neutrophil try to engulf the bacteria, there will be some mechanism, as you all know, the phagocytic activity. Because of this phagocytic activity, the microorganisms get attached to the neutrophils and they try to destruct the periodontal pathogenic bacteria. During this host and in microbial environment or host microbial war, there will be a destruction of some amount of the neutrophils also, leading to exudate or leading to what to call it as neutrophils getting the content of the neutrophils get into the connective tissue of the gingiva, resulting into the loss of attachment or crustal resorption, wherein the gingival inflammation will extend to the periodontal pocket, leading to destruction of the periodontal ligament fibers, cementum, alveolar bone. Now, coming to the how does this bone destruction of the gingival destruction will occur in case of inflammation. Now, there are certain pathways which have been established for the extension of gingival inflammation into the underlying periodontium. One pathway is directly from the gingival connective tissue to the alveolar bone or the crust of the alveolar bone, wherein the bone destruction occurs because of the extension of the inflammation into the underlying alveolar crust of the alveolar bone or into the cancellous portion of the alveolar bone, or this might extend from the alveolar bone into the surrounding periodontium, leading to what we call it as periodontal bone destruction. Or the second pathway is your periosteum. Now, the gingival inflammation will follow a normal pathway wherein the inflammation will extend into the outer cover of the alveolar bone called as periosteum, and from the periosteum to the underlying cancellous bone, leading to destruction of the alveolar bone. The third possible pathway is direct encroachment or direct attack on the periodontal ligament fibers, which will usually leads to establishment what we call it as vertical defects, which will be discussed in the further session. Now, this is in brief regarding the pathway of inflammation. Either one is directly it can go to the alveolar bone, causing destruction of the alveolar bone. From the alveolar bone, it can extend to the gingiva, or from the gingival connective tissue to the periosteum, and via the periostal damage to the periostal membrane, leading to extension of the inflammation into the alveolar bone, causing complete alveolar crust destruction. Or the third possible mechanism is usually seen in trauma from occlusion, where the pathway of inflammation is altered, and from there the gingival inflammation will extend into the periodontal ligament. Now, this gingival inflammation will usually attack the marrow spaces, and it replaces it by the leukocyte fill or the exudate, which will be collection of the blood vessels or rupture of the blood vessels, leading to what we call it as inflammation and destruction of the alveolar bone. Now, once there is some collection of the fluid or exudate, and there will be proliferation of the new blood vessels around that area, that is called as angiogenesis, and also the proliferation of the fibroblasts. Now, these fibroblasts are called fibroclast also because they have the phagocytic activity. Both the fibroblasts will perform both the deposition activity also and destruction activity, leading to stimulation or the activation of the osteoclast or the mononuclear, what we call it as mononuclear phagocytes, will get activated, and these osteoclasts will cause destruction of the alveolar bone. Now, this will occur somewhere around the marrow spaces only, and this will lead to destruction of the alveolar bone. If the pathway of inflammation is altered, as in case of the previous slide which I have shown, into directly the periodontal ligament, there will be destruction of the collagen fibers of the periodontal ligament, and this destruction of the periodontal ligament fibers, if it extends beyond the alveolar crust, will lead to formation of what we call it as infrabony pocket, otherwise we will call it as suprabony pocket. Now, let's get into what is radius of action. Now, the presence of, you all know there is presence of some gingival inflammation products, as well as the presence of microbiology, and there is a host microbial interaction going on around the tooth surface. Now, these locally produced bone resorption factors may be present proximate to the bone surface, as in case by the periodontal pocket. Now, if this plaque induced inflammation can be present within the bone loss, can cause bone loss if it is available within 1.5 to 2.5 mm radius. Now, this is something called as Weir-Ock concept, wherein if the bone loss is, if the plaque can, there is a study related to the effect of the plaque induced microorganisms or the effect of the plaque induced microbiology into the underlying periodontal ligament, called as Weir-Ock concept, wherein in Weir-Ock concept there is induced bone loss. The bone loss is induced in the periodontal disease, and this induced bone loss will act within the radius of 1.5 to 2.5 mm. Beyond this 2.5 mm, there is no effect. Now, for example, if you consider a case of anterior teeth bone loss, the bone or the crest of the alveolar bone present between your interdental septa, or the interdental septa present between the two teeth of the anterior will be less than 1.5. In such cases, you will encounter complete destruction of the alveolar bone. If the plaque-induced microorganisms or the periodontal disease has sets in, it will lead to complete loss of the alveolar bone. Now, similarly, in case of mandibular molar or maxillary molar, where the bone is sufficient or the interdental septa is wider, and there if the plaque induced microorganisms are present, this can cause an effect within the radius of 1.5 to 2.5 mm. Beyond that, if it is there, if the interdental septa is very small, it will lead to horizontal bone loss. If the interdental septa is very thick, it will lead to what we call it as angular defects. You can encounter all these angular defects or vertical defects in case of molars in upper maxillary and lower maxillary or lower mandibular teeth. This is the concept of your radius of action. Means in that particular radius there will be destruction of the alveolar bone going on, and if the bony septa is very much thin, it will lead to complete loss of alveolar bone leading to horizontal defect. If the bony septa is very thick, it will lead to vertical defect. Now, this rate of bone loss, there is something called as rate of bone loss also. Now, I have discussed regarding horizontal bone loss and vertical bone loss. This rate of bone loss was first discovered by low and poor workers, where in Sri Lankan tea laborers, they assess the amount of the alveolar bone loss occurring within 1 year, and in 8% of the individuals, it was seen that it was severe bone loss with yearly attachment loss of around 0.1 to 1 mm. What is that clinical attachment loss? It is nothing but the distance between the CEJ to the base of the pocket occurring, or the bone loss occurred, and its rate is somewhere around 8% cases of severe periodontal disease and 81% of the moderate periodontitis, where the clinical attachment loss is negligible, and still 11% of the individuals in Sri Lanka tables where there was no access to the oral hygiene procedure, there was only 11% of the bone loss present, and the 11% of the patient population had bone loss of 0.05 to 0.09 mm. Means the host is very strong, even though the patient were not brushing properly and they were not accessible to oral hygiene modern oral hygiene procedures. The rate of the bone loss was very less. In some individuals, the rate of the bone loss was very high, and in some individuals, and it was moderate in few individuals. Now, this led to the concept of what we call it as host modulation, or the host is also responsible for the occurrence of the periodontal disease. Now, this period of destruction of periodontal disease will occur because of the loss of the collagen or alveolar bone and leading to deepening of the periodontal pocket. Now, this deepening of the periodontal pocket is not a constant phenomena. So they came with the concept of what we call as burst of disease activity. What is means by burst of destructive activity means there is subgingival accumulation of periodontal pathogenic microorganisms, and on these microorganisms will lead to destruction of the periodontal disease. Now, if the immune response is very much high, this destruction will be subsided and will have quiescence phase, where the destruction of the periodontal pocket will never occur. No, they came to a conclusion that because of the constant destruction and constant repair activity occurring between the host and the periodontal pocket, within the periodontal pocket, the destruction of the periodontal disease occurs in burst, and they came to the theory what we call it as burst of destructive activity, or the destruction activity or the periodontal pocket is not a constant phenomenon. And this burst of destructive activity will coincide with the conversion of the T lymphocytes into the B lymphocytes, wherein the plasma cells or the B lymphocytes will increase. This will is an indication that there is some destructive activity going on, leading to alveolar bone loss. Now there is also increase in the loss of attachment, or there will be increase in the gram-negative anaerobic flora and subside, and conversely there will be a decrease in the aerobic flora. And when the destructive activity is stopped by some means of the patient is brushing properly, there will be end of this and lead to the what we call it as quiescence phase, where there will be increase in the gram positive organisms, and this subside, and this will correspondingly subside the gram negative bacteria. When the tissue invasion occurs, this bacteria will encounter into the connective tissue of the periodontium also, and will cause destruction of the alveolar bone. And also this is something called as period of destruction. Now in a person, constantly there will be no disease activity in sometimes where the pocket is normally healthy and fibrotic, and sometimes you will have an inflamed periodontal pocket where the destruction activity is very high. So it is an indication clinically that the destructive activity is going on. If the pocket is fibrotic with less amount of bleeding, when you probe that, it means that it has gone from active destructive state to a quiescence stage. Now this mechanism of bone destruction and host also will have host mediator factors such as presence of interleukin, TNF alpha. All these will be liberated into the gingival connective tissue. Now this to prevent this, there are certain drugs which will produce like ibuprofen or PGE2 inhibitor, which will cause destruction, which prevent actually destruction of the alveolar bone, so that the alveolar bone loss can be prevented in a certain extent. Now coming to something called as bone formation in periodontal disease. As I said, there will be destruction activity as well as collection activity occurring within the periodontal pocket. So there are certain areas where the bone formation will occur. Now this bone formation is only by presence of osteoblast, and this area of bone formation are also found immediately to active resorption area. The response of the alveolar bone to inflammation includes bone formation and bone resorption. Now the bone formation retards the rate of bone loss, compensating some degree of the bone destroyed by periodontal inflammation. Hence, when the patient suffers from periodontal pocket, he does not have continuous bone loss. As I said, rate of bone loss will be somewhere around 0.05 to 0.1 mm in all. So this 1 mm bone loss will not be a constant. There will be some amount of deposition of the alveolar bone, preventing the destruction of the alveolar bone. Now, if the host response is very much high, or the microorganisms or the virulence factor of the microorganisms is very high, this will lead to bone resorption. Or if it is very less, it will have some degree of bone deposition. And this bone deposition and bone resorption, if it is not matching, that will lead to destruction of the alveolar bone. Now, there is one more entity called as trauma from occlusion. This trauma from occlusion is also causes increased in the inflammation and alter the what we call it as pathway of inflammation, leading to direct bone resorption or bone deposition. Now, in case of orthodontic treatment, you might have come across where the areas of tension, areas of pressure. Where these areas of pressure, there will be bone resorption by activation of your osteoclast. And in case of bone deposition, where there is persistent stretching of the periodontal ligament fibers, in case of tooth movement, there will be bone deposition. So, what are the factors? Or there's something called as bone factor concept in periodontal disease, which was introduced by Glickman. When the bone is already destructing, these factors such as your hypoplasia or the osteoporosis, osteopenia, hyperparathyroidism, all these will have a systemic influence. For example, you take case of diabetes mellitus. Now this diabetes mellitus will also have a confounding effect on the rate of the alveolar bone loss. Now these factors were collectively called as bone factor concept in periodontal disease, where not only the periodontal disease is purely caused by microorganisms or the host, but also influenced by diseases such as systemic diseases such as your diabetes mellitus, osteoporosis, osteopenia, hyperparathyroidism, leukemia, or any other systemic diseases. Now, what are the factors which are responsible for the determining bone morphology? These are your normal variation of the ulnar bone, a presence of exostosis, your trauma from occlusion, and buttressing bone formation. Thank you for your patient listening. Next class we will continue with the varieties of the patterns of the bone destruction, like your horizontal bone loss, osseous defects, vertical or angular defects will be covered in the next coming classes.